Good morning, everyone. I think we're going to get started. I'm Jeff Miller. I'm a faculty member, a psychiatrist in Area Mind, and I'm honored to be moderating today's special Grand Rounds, which is a Hot Topics Grand Rounds. This is the third annual Hot Topics Grand Rounds that we've had in the department. It was, I would say, a brilliant idea of Jonathan Posner and Melissa Arbuckle. And the idea of this Hot Topics Grand Rounds is very consistent with some of the goals of the strategic plan for the department and for NISP that came out in recent years, primarily to increase communication and collaboration across the areas. Oh, I just got a note that the idea also came from Myrna Weissman, so I want to acknowledge her important role in this as well. A big goal of this was to increase communication and collaboration across the different areas of NISP. And we find, I think many of us who have been at NISP for some time have had the experience that there are people down the hall, up one flight or down one flight who are doing fascinating work that we don't know about for years even. And when we learn about what our neighbors are doing, it can stimulate our own research ideas. It can stimulate opportunities for collaboration. It can stimulate opportunities for mentorship of trainees. And so the idea of Hot Topics is to try to facilitate all of that by hearing about exciting, cutting edge work by a diverse group of our faculty who are studying a diverse group of topics. And I think we have a great lineup in store for you today along those lines. We're going to hear from 3 of our faculty, and we have sequenced their talks along a trajectory. The first talk will be focused on prenatal and environmental effects on brain development. The second talk will be focused on adult psychopathology. And our final talk will be focused on psychiatric treatment and prediction of treatment outcomes. So we're moving from early life to adult psychopathology to treatment in the talks that we'll hear from today. What we're going to do in terms of like how we structure our time is that we're going to hear from the 3 speakers sequentially, and then at the end we're going to have a discussion time. So probably around 12-ish, 12 give or take. We'll move into an open discussion in which I will read questions related to all 3 of the talks. Simon has already posted in the chat, if you go into the chat, instructions about how to ask us questions. If you hover to the bottom of your Zoom screen, you'll see the Q&A function. And I would invite you to not wait. If you have questions that occur to you during the courses of the 3 talks, feel free to post them in that Q&A section. We just won't get to them until we go to the discussion section after the 3 talks are done. So I'm very pleased to introduce our first speaker today, Dr. Marisa Spann. Dr. Spann is the Herbert Irving Associate Professor of Medical Psychology in the Departments of Psychiatry and Pediatrics. She received her PhD in clinical psychology from George Washington University, as well as 2 additional graduate degrees, an MPH in social and behavioral sciences at Yale. Sorry, I lost my screen. Here we go. And an MS in clinical research methods in our own biostatistics department. The overarching goal of her research is to identify early immune, brain, and neuropsychological antecedents of childhood psychiatric risk to reduce the time to intervention for young children. She's using 2 complementary approaches to studying this, one involving national and international birth cohorts, and the other clinical samples of pregnant women. And very interestingly, in addition to this research agenda, Dr. Spann co-founded and is an executive board member of the Fetal Infant Toddler Neuroimaging Group. And locally here at Columbia and in our department is the assistant director of the Office of Equity, Diversity, and Inclusion. So we're thrilled to have Dr. Spann speaking with us. And the title of her talk today is Intergenerational Pathways, the Effects of Maternal Experience of Discrimination on the Offspring Brain. Welcome, Dr. Spann.
Thank you so much, Jeff, and thank you all of you for having me here. I'm really looking forward to talking to you about work in progress, really, related to the effects of maternal experience of discrimination on the offspring brain. So first, let me just provide some scaffolding of what discrimination is, or a good definition. And I'm putting this in the context of racial discrimination, but we know there are different types of discrimination, including social discrimination as well. So it would be defined as treating someone unfavorably because of their race or personal characteristics that may be associated with race, so skin color and facial features. And discrimination is considered a psychological stressor. And it's well established within adults in particular that there's increased risk for psychiatric and mental health disorders because of discrimination. What's not as clear is what are the neural substrates or the neural effects associated with discrimination. And so that's some work I'm hoping to contribute to here. And so discrimination during pregnancy has also been considered. And similar to non-pregnant adults, there's increased psychiatric symptoms. And there's also been found to be associations with physical outcomes during pregnancy. For example, increased inflammation in the context of already increased inflammation during pregnancy, as well as increased risk for gestational diabetes. And then of particular concern is some women during pregnancy may delay prenatal care because of either concerns of discrimination or potential experience in the healthcare setting. No work thus far has been done to look at the effects of discrimination on the pregnant woman's brain and so, or their offspring. And so what I'm drawing from today is work that's been done in adults. So kind of taking a step further into development. What we know about discrimination in the brain in adults is there's been a very few studies, but one particular study stood out by Clark et al. In 2018. And that study was had a predominantly Black adult sample. And what they found was social discrimination was associated with increased brain connectivity between the right and left amygdala, as well as increased connectivity between the amygdala and brain regions that are involved in emotion regulation, attention, executive control, reward circuitry. And but what stands out here is that the amygdala seems to be a consistent player involved, which we know is involved in affective regulation and emotion regulation as well. And their findings were actually independent of psychological stressors, so really suggesting that discrimination in and of itself has its own unique effects on the brain. And the other literature that you can draw from are a more sort of expansive studies related to face processing and how individuals process race. And so a number of the studies compared racial face processing of Black and white individuals. And so really they're trying to look at sort of in-group versus out-group face processing. And what they consistently found is that when minority adults are processing the other face, there's increased or decreased amygdala connectivity with some of those similar brain regions that I mentioned earlier. So really seeing a pattern of consistent brain regions that might be associated with discrimination. So this information is really helpful in terms of helping to provide some scaffolding of this work in pregnant women and their offspring. And in terms of directionality, just wanted to say that in minority groups, there were sort of variability in terms of whether these connections were increased or decreased. So intergenerational transmission. So I saw it in this work and myself and my colleagues to understand how the pregnant women's experience of discrimination translated to the developing fetus brain. And based on the existing literature, I proposed that increased discrimination would be associated with weaker neonatal connectivity in brain regions involved in racial processing and discrimination. Is particularly interested in the amygdala as a region of interest, as well as the prefrontal cortex. And from our own prior work, looking at the effects of perceived stress more generally, we found that the hippocampus is is highly involved, and we know that it also plays a role in connection with the amygdala in terms of emotional memory, and so that was an area of particular interest as well. So in a sample of 45 adolescent pregnant women that were drawn here from Columbia University, um, we were able to do a longitudinal study to assess a number of different factors, but we were able to also measure the experience of discrimination as well as other psychological factors. And it was a predominantly Latinx sample. So the women were recruited either in the second or third trimester, and as well as having a number of psychological measures, they also underwent fetal behavioral assessments and biospecimens were collected. And then in the newborn period, their infants came back for an MRI, and follow-up behavioral assessment continued. And we're actually following this sample at school age right now, preschool school age, as part of an existing R1. So it's nice we can continue to see the effects of prenatal exposures in this sample. And the demographics, just to show, this is a healthy sample who were receiving prenatal care. Wanted to really that was really important to us, just to really ensure that this was a sample that, there weren't going to be a lot of potential other confounds to consider. So on average, the moms were 18 years of age. As you can see, predominantly spontaneous vaginal delivery at around 70%. The sample was predominantly male, and you can see that the gestational age at birth and birth weight, as well as APGAR scores, are all within the normal range. So I like to show this slide because just to really kind of really bring home the fact that the procedures that we use to scan infants that are very safe. And this is really cool because this is actually an infant MRI. We don't have one of those here, but there are some sites that do, because we do think it's really important to study young children as well, to similar to increasing underrepresented minorities who are not typically in research studies. We think it's also important to study young children. And so our protocol, we dedicate a lot of time to the newborn scan session. The moms are part of that process. They're changed into MRI safe clothes, they're fed, they're swaddled, and they naturally fall asleep. There's no sedation. And whenever they're in deep sleep, then we put them in the scanner and they sleep through the scan. So in terms of the specific imaging modality that we were considering for this particular study, so we use the resting state functional data. Again, they're asleep during the whole scan session, so there's no tasks involved. And what we're looking at is functional connections between different brain regions. So just taking kind of an example, so we have this brown area and this green area, and we're pulling out the time courses, and we're correlating the average time courses between those two brain regions. And if there's high correlation, we'd say there's high connectivity. And in contrast, if we take the purple region and the teal region and correlate their average time courses, if there's no significant correlation, then we'd say there's low connectivity. And so for the purpose of this study, as I mentioned, there are particular regions that we're interested in and looking at how they were associated with the whole brain. And so those regions are the amygdala, the left and right sides, and the hippocampus, the left and right sides. So those are our regions of interest. And so that would be like the areas that would be targeted here. And we're doing analyses to look and see their association with other regions in the whole brain. And then we're able to obtain maps that show us those relationships in the context of discrimination. And so just to provide some further scaffolding, so I'm going to show a brain that shows all the results of these correlations. And if they're cool colors like the purple, there'd be decreased significant connectivity or correlation. And if they're warmer colors, then it would be increased connectivity. And this again is all in association with maternal experience of discrimination during pregnancy. So first finding is with the right hippocampus. We found that with increased maternal report of discrimination, there was decreased connectivity between the right hippocampus and the dorsolateral prefrontal cortex. As you may remember from the previous studies with discrimination and racial other face processing, the dorsolateral prefrontal cortex was an area that was involved or significantly associated. We didn't have significant findings with the left hippocampus. And then in terms of the amygdala findings with increased maternal discrimination, we found decreased connectivity between the left amygdala and the anterior portion of the prefrontal cortex, which is involved in goal pursuit, future goal directed behavior. And the right hemisphere had no significant findings, and so that's why it's not shown here. So just to recap and summarize, this is, as I said, a work in progress. There's more to come with this, but it would be the first study to look at the intergenerational transmission of the effects of discrimination. And the main findings were that with increased report of discrimination from the pregnant woman, it was associated with decreased connectivity between the hippocampus and amygdala and aspects of the prefrontal cortex. And these findings were pretty consistent with the prior studies that I mentioned related to race facial processing and experience of discrimination in adults. So we have a number of next steps, and I think these results really kind of provide a pathway for them. We have ongoing analyses looking at the interaction between maternal stress and acculturation and how those factors may potentially moderate these relationships. We are also particularly interested in fetal development, and we're considering fetal growth and birth outcomes in association with this. And I think prospective longitudinal studies, and this is something I'm considering with future work, it would be nice if we could be considering this intergenerational model as we're looking at the development of racial face processing during infancy, because we know that is something that is formed by 9 months. And so looking at it longitudinally over time, in the context of this, of discrimination, could be really rich in terms of understanding the further development of this process. And I think additional psychological outcomes that map onto these brain regions, like emotion regulation and attention, could also be particularly useful when thinking about interventions. So I'd like to thank my collaborators, my research team, the study participants. Obviously, we could not do this without them, as well as funding agencies. And I would like to thank all of you for listening to me today.
Great. Thank you very much, Dr. Spann, for that excellent talk. As I said, in case people joined a little after we got started, we have 3 speakers today, and we will have questions at the end of the 3 talks. But if you want to get your question down before you forget it, feel free to go ahead and put it in the Q&A section of the Zoom. If you hover to the bottom of your screen, you should see a Q&A button that you could click and feel free to ask any questions now. But we're going to move on to our second speaker, Dr. Elizabeth Sublette. Dr. Sublette is an associate professor of clinical psychiatry here at Columbia. She received her MD and PhD in neuroscience from SUNY Downstate and completed psychiatric residency at the Zucker Hillside Hospital, North Shore, LIJ, and then served as a chief of the affective disorders inpatient unit at Zucker Hillside Hospital before continuing additional academic training here at Columbia. She came to Columbia and NISP for postdoctoral research training in the MIND group with Dr. John Mann, and subsequently joined our faculty. Dr. Sublette's research focuses on the neurobiology of mood disorders and suicide risk. And in particular, she's concentrated on understanding the effects of omega-3 fatty acids on brain and mood. And Dr. Sublette has used a broad array of techniques to get at those questions, including assays of peripheral blood, MRI imaging, PET imaging, and quantification of the gut microbiome. And we'll hear about a few of those today. Her research has been funded by NARSAD, AFSP, the American Foundation for Suicide Prevention, and NIMH. And the title of her talk today is Serotonin, Depression, and Fatty Acids. Welcome, Dr. Sublette. We're looking forward to hearing your talk.
Thank you, Jeff. Can everyone hear me?
Yes.
Okay. Yes, thanks again. And it's an honor to be here. And I'm very pleased actually that I get to do a Zoom presentation rather than facing a giant auditorium full of people, sort of a pandemic silver lining. So I'm going to talk today about my work with polyunsaturated fatty acids and how that in one of the studies that I'm going to be presenting today, how that may relate to serotonergic functioning and major depression. And I have no conflicts of interest to declare. I'd like to begin by just doing a little brief background on the biochemistry of fatty acids. Pictured here is a glycerophospholipid molecule. These are what make up the lipid bilayer in the plasma, in the cell membrane. And here's the glycerol backbone, and here is the phosphate moiety makes the molecule amphipathic. And here we have fatty acids. So you can see even this cartoon sort of captured how a fully saturated fatty acid has got a very rigid kind of a configuration, whereas the addition of a double bond, which is what makes it unsaturated. Here we have a monounsaturated fatty acid. You can see how the addition of this can create some flex in the molecule. So the polyunsaturated fatty acids have multiple double bonds. And so this flexibility, the length of the chain and the flexibility that it gives, that the double bonds provide, create really important physicochemical characteristics, and which translates to effects on the membranes and other effects of polyunsaturated fatty acids, or PUFAs, as I am going to refer to them at sometimes. So in terms of the nomenclature, we have here two of the most important omega-3 fatty acids. And you see here that this is a 20 carbon, EPA is a 20 carbon molecule with 5 double bonds and a double bond. The first double bond is found at the third carbon, and that's why it's called N3 or omega-3. And here we have probably the most important or relevant omega-6 molecule, which is arachidonic acid. And the omega-3 and the omega-6, as a general kind of principle, they have some competitive relationships, some opposite effects, so that the omega-3s tend to be generally anti-inflammatory, whereas the omega-6 tend to be pro-inflammatory. So in this cartoon, you can see this kind of a depiction of the plasma membrane, and the phosphate moieties are hydrophilic, so that they're in contact with the internal or the external aqueous environment. And the lipid part here is shown here with the little fatty acids. Now, PUFAs are really dynamic molecules. As I was saying before, they have this sort of fluidity, and that affects the fluidity of the entire membrane. Sorry, technical difficulties. PUFAs in and of themselves have second messenger functions, and they are precursors to other active molecules. So their metabolites include, for arachidonic acid, the prostaglandins and leukotrienes, and metabolites of the omega-3s include the docosanoids, such as resolvins and protectins. They also have roles in bioenergetics, and they bind to PPARs, which are nuclear receptors that regulate gene expression. So they're not, the lipids are not just some kind of furniture that's, structurally holding the cell together. There's a lot of dynamic things going on. I have a lot of cartoons in this presentation. So here we have a depiction of a lipid raft or a lipid microdomain. And these are considered to be very also dynamic segments of the membrane where cholesterol and sphingolipids are in high concentration, and they're very sort of rigid, bulky molecules, and they tend to cluster together when they're sort of, I like to think of it as sort of herded together by their aversion to the properties of the fatty acids in the phosphoglycerides and the rest of the membrane. So the PUFAs can have effects on membrane fluidity that influence the order and the size of these lipid rafts. And that's relevant because in the lipid rafts is where a lot of the membrane-bound proteins are found. And so effects of PUFAs on the fluidity affect the lipid rafts, and that can impact neuronal responsivity and the functions of membrane-bound proteins such as transporters and receptors, and have actual functional effects. So that's kind of a background to what I think may be the central biochemical processes that could relate to the findings that I'm about to describe for you. So I'm going to talk about results that we got with a study protocol using the DAS, high affinity radioligand in PET scanning. So it's a high affinity ligand for the serotonin transporter, depicted with this abbreviation. So this is about a study that was Dr. Mann was the PI on, and he got NIH funding to do a big study to look at relationships between serotonin transporter binding and depression and anxiety. And I was lucky enough to get a NARSAD grant to do an add-on to this protocol, in which we, in a subset of the participants, we took blood and we studied plasma PUFA levels. The subsample that we ended up with was 21 medication-free patients in a major depressive episode. So we did not look at the controls in the study that I'm about to describe to you. In the study design, we selected a priori 6 brain regions of interest on the basis of having measurable serotonin transporter activity, and also that have been associated previously with the neurocircuitry of depression pathophysiology. So we looked at amygdala, anterior cingulate, hippocampus, midbrain, putamen, and thalamus. So I'm really interested in how serotonin transporter binding relates to PUFAs. But the bigger picture is, how do these things potentially relate to depression and behavioral symptoms? So the analysis pathway was that we used mixed models. We first looked at linear relationships, but as you'll see from the data that I'm going to show you, there was a very clear nonlinear relationships observed. So in our final model, quadratic term was added. Excuse me. So the predictors were the PUFAs, these 3 PUFAs that we assayed and looked at, and the outcome measure was serotonin transporter binding potential. So we log transformed both the PUFAs and the binding potential in order to mitigate skew. And we looked at all of the PUFAs, but we didn't see any effects of the omega-3s in terms of any kind of relationship with serotonin transporter binding. So what I'm going to be telling you is it's all about what we found with arachidonic acid. So we used the BPP version of binding potential. There are several different flavors of binding potential, ways to measure it. And I'm not going to go into the nuances of that now, but you can read about it in our article if you're interested in that. And the fixed effects were brain region, and we ended up using these brain regions in an aggregated way. And the other fixed effects were PUFA levels. And we tested for age and sex, but they had no effect, so they were removed from the model. Random effect was subject to account for potential correlation in binding across regions. And then we ended up doing a mediation analysis. So here are the data. Here we see that the relationship between arachidonic acid and BPP. We see it's got this inverted U shape. The different colors are each of the different brain regions, and you can see that the relationship is sort of acting in concert there. Nothing stands out, nothing stood out in terms of individual brain regions. So that's why we aggregated them in when we did the modeling. I want to point out that this is a cross-sectional study. So we're looking at correlations, associations. We're not really able to say anything about the longitudinal or prospective causality, directionality, but I may slip up and use that kind of language because I sort of think about it in terms of how this might, the model that this might be in terms of what's happening. So we see here that this relationship is a significant one between the arachidonic acid plasma levels and transporter binding. If we look at the relationship between transporter binding and depression scores, we see a very robust positive relationship. This hasn't been seen in all the literature does not all has not all found this, but we certainly saw a very, like I said, a robust relationship here with a p-value of 0.0003 in terms of serotonin transporter binding and depression severity using the Hamilton scale. Now, so thinking about this, so this means that lower transporter binding is associated with lower depression. And so the way that I think about it is that the lower transporter binding then can result in increased free serotonin in the synapse, and more serotonin is generally associated with antidepressant effects. The third piece of the relationship here is the relationship between arachidonic acid and depression. And so we see here this really very clear, again, inverted U shape, a significant relationship statistically. And so there appears to be some complex relationship between the dose, the concentration, I should say, of arachidonic acid and this behavioral measure. So if I lay it out again, the relationship between arachidonic acid and transporter binding is significant in kind of a complex way. In turn, serotonin transporter binding was very significantly associated with depression severity. And in a simple model in which we just look at arachidonic acid and depression severity, we also see significance. Now, how could the concentration of this fatty acid relate to depression severity? What's happening biologically that would make that connection? So we hypothesized that the arachidonic acid may have effects on the transporter, and then the transporter may have effects on depression severity. So focus here on these p-values, and when we put everything together into one model, we see that the p-values between arachidonic acid and depression severity are no longer significant, and this is consistent with a classic mediation model in which the inclusion of the mediator in the model attenuates the effects of the predictor on the outcome. So we think that the arachidonic acid could be affecting transporters, affecting severity. Once again, actually what we have here is a set of associations that we've measured. So cross-sectionally, it looks like mediation. I'm going to just go over some of what's known about relationships between serotonin and arachidonic acid to just kind of get down in the weeds a little bit in terms of possible molecular understanding of this. So dietary arachidonic acid crosses the blood-brain barrier where it can exist as free or unesterified arachidonic acid, which goes in and out of membrane, being bound to the membrane. And the cleavage of arachidonic acid from the membrane is facilitated by cytosolic phospholipase A2. Now it happens that serotonin, when it binds to the serotonin 2 receptors, 2A or 2C, stimulates PLA2. And so it tends to move this relationship in the direction of free arachidonic acid. Conversely, if serotonin binds to the 5-HT1A receptor, it tends to move the relationship in the opposite direction. So this looks very biological, right? We have this kind of homeostatic, potentially homeostatic processes going on. In addition, the unesterified arachidonic acid has been shown to, the metabolite, one of the metabolites, which is anandamide, which is an endogenous cannabinoid that binds to the cannabinoid 1 receptor. So there are studies that have found that affects serotonin levels and also serotonin transporter binding. Now, all of these steps that I put here, that each one is supported by 1 or more articles. These studies were mostly done in animals. And then a little more hypothetically, we think that the free arachidonic acid, which can affect lipid rafts, and then via modulation or regulation of lipid rafts may affect the transporter binding. Now, if we look at lipid raft studies done mostly in cell cultures, they have found that serotonin transporter localizes in lipid rafts, and it's essential for serotonin uptake. And this is consistent with findings that the transporter co-localizes with lipid raft markers like caveolin and ganglioside GM1. And in serotonergic neuronal cells, transporters cluster in cholesterol-rich membrane microdomains. You'll remember the lipid raft cartoon that I showed you. So manipulating cholesterol, like in this case, if the cholesterol depletion studies cause a decrease of 50% in serotonin transport rate. And if you're interested in this, we published a systematic review looking at relationships between lipid rafts and monoaminergic transporters and receptors. Now, going even further, deeper dive into the molecular levels of things, studies in biological model membranes, where they throw lipids into test tubes essentially and measure what's going on. There's quite a robust literature concerning effects of omega-3 on lipid rafts. And there are some studies also showing that omega-6 arachidonic acid has effects on lipid rafts. So the take home here is that arachidonic acid in this study appears to affect depression severity. It was correlated with depression severity, and that seems to be mediated by arachidonic effects on serotonin transporter binding. So I'm going to just review those mechanisms that I talked about as the putative speculative mechanisms, because we know that PUFAs like arachidonic acid have effects on cell membrane functions, in part through their effects on lipid rafts. PUFAs may regulate serotonin transporter binding specifically via lipid rafts, and we know that serotonin can modulate depression. And as we saw, there's some kind of homeostasis where serotonin can have reciprocal effects on arachidonic acid. So this is our model for what may be happening here. And this pilot study, I think, has a very, very exciting results, and we're hoping to move in the direction of studying more about the lipid raft piece of it. I'd like to thank our team. Manesh was a medical student who took these data out of the data bank where I had them, and I hadn't really worked on them, and he moved this into fruition. Our wonderful brain imaging team handled all the PET analysis. Serena and Todd did the statistical heavy lifting. Tom Cooper did the PUFA assays, and Doctors Okendo, Sullivan, and Mann were the original designers of the DASP study and the clinical studies that brought the patients and looked at the relationships with serotonin transporter and depression and anxiety. Thank you for your attention.
Great. Thank you so much, Elizabeth, for that wonderful talk. Please feel free to post questions for Dr. Sublette in the Q&A at the bottom that we'll get to when we have our discussion after our final speaker. So I'm very pleased to welcome and introduce our final speaker for today, Dr. Sean Luo. Dr. Luo studied physics and mathematics at the University of Chicago and received an MD and a PhD in theoretical and computational neuroscience from Columbia University. He completed his clinical training in psychiatry and in addiction psychiatry, also here at Columbia and NISP. And Dr. Luo currently leads several federally funded research programs focusing on applying computational neuroscience, data science, and machine learning techniques to addiction science to improve patient treatment match, which is a nice term. I think, I'm curious, Dr. Luo, you'll tell us how that overlaps with concepts of personalized medicine. He serves on the Data Science Task Force for the National Drug Abuse Treatment Clinical Trials Network and on the Industry Academia Government Relations Committee for the College on Problems of Drug Dependence, the longest standing group of addiction researchers and clinicians in the United States. And Dr. Luo's talk today is titled Individual Level Predictive Modeling of Opioid Use Disorder Treatment Outcome. Thank you and welcome, Dr. Luo.
Thank you, Jeff, for this very kind introduction. I just want to thank also the Grand Rounds Organizing Committee for inviting us to talk a little bit about opiate use disorder and my work here, which is funded by the National Institute of Health HEAL Initiative and also carried out through this umbrella work, the group, the Clinical Trials Network. Opiate use disorder continues to be a dominant part of our conversation in public health in 2021. And while there has been a recovery of opiate overdose in the last couple of years as medication treatment has been widely disseminated, more recently, in the context of COVID-19 epidemic, there's a further rise of opiate overdose, primarily driven by high potency opiates such as fentanyl. And therefore, the question of how to improve treatment outcome and how to better find treatment patient match in this entity remains important and of increasing importance. And recovery from opiate use disorder follows a complex trajectory, which has been outlined by faculty members in our department, Robin Williamson and Nunez, in this paper on Cascade of Care, which shows that there are really stages. The diagnosis of opiate use disorder is not a binary label. Many people exhibit certain behaviors that are characterized as at-risk use. They may not be meeting all criteria for opiate use disorder, and the task for dealing with these people is one of primary prevention. Once you start to engage with treatment and start to meet formal diagnostic criteria, we have a number of treatment options for you to get you into abstinence. And subsequent to that, the goal is to maintain you in the abstinence category and deal with inevitable problems that are associated with relapse. And the problems we're dealing with today has to do with understanding how the initial treatment engagement works, which is when someone who comes into the clinic with a diagnosis of opiate use disorder and you want to initiate treatment, you want to understand two important questions. One is, at the start or early on in treatment, can we predict the probability of abstinence at the end of the treatment? And second, if a particular patient was inducted on a different medication, whether or not the predicted probability would be better. And this is this question of patient treatment match. And these are questions that I get asked by patients and family members in the clinic while treating them. And the research agenda is really initiated by this clinical need. And a brief review of medications that are currently FDA approved for treatment of opiate use disorder. The oldest is methadone. It's a full opiate and agonist, and there's no induction phase, which means that you don't have to stop using any opiate before you can start taking methadone. It's delivered in a restricted context through federally licensed programs. The second medication is buprenorphine, which is a partial agonist for the opiate receptor. There is a short course of induction where individuals need to be in some form of opiate withdrawal. It can be delivered in an office-based context. The third agent is extended release naltrexone, which is a full antagonist for opiate receptor and requires a longer period of induction to avoid precipitated withdrawal, and is also office-based and can often be delivered required to be delivered in a hospital context. And the most recent approved agent is extended release buprenorphine. And it's similar to oral buprenorphine, but lasts between 1 week and 1 month, and can carry potentially a shorter induction phase. Of all 4 treatments, the first 3 have undergone rigorous testing through large randomized implementation studies via the National Drug Treatment Clinical Trials Network, CTN. And the 3 studies of which the data I'm going to scrutinize will be presented here. The first study is called CTN 0027 START, which randomized over 1,000 individuals from 8 federally licensed outpatient treatment programs to buprenorphine or methadone, and they were followed for 24 weeks and eventually tapered or referred for maintenance. The second study is called CTN 30, which randomized 653 individuals with a diagnosis of prescription opiate use disorder. And so that's a little different from the cohort for CTN 0027, which is predominantly a heroin-using cohort. And these individuals were randomized to 2 different psychotherapy programs. And they were inducted on buprenorphine and tapered, and then eventually reinducted and maintained on buprenorphine. And the third study, which was most recently completed, is called CTN 0051, which randomized 570 individuals who were a mix of heroin use and prescription opiate use. But they were only recruited from inpatient opiate treatment facilities. And these individuals were then randomized into extended release naltrexone or buprenorphine inpatient after a formal inpatient detoxification program. And then they were followed for 24 weeks as well. And so as you can see, these are 3 relatively heterogeneous cohorts of individuals subjected to treatment using medications for opiate use disorder. But we could harmonize the common elements in these 3 studies to come up with a harmonized data set, which is more extensive compared to each of the individual studies, including over 2,000 individuals who met the diagnosis of opiate use disorder, who provided 6 months of weekly urine toxicology screens and self-reported drug use, and had relatively uniform collections of baseline measures. And we also decided that because we could utilize the resources that are available, the expertise that exist in the CTN, we should design a multi-site data science project where we cleaned and harmonized the data collaboratively, and then we can provide a reusable database that's comprehensive enough for all of the future researchers within and outside of CTN to scrutinize this data set that's well documented and curated. And the harmonization process itself is complex, and we're in the middle of documenting all the features. As you can imagine, each individual clinical trial contains a large number of databases encapsulating each aspect of the study that was carried out. And we have to understand what each of these databases mean. And even within a particular survey domain, for example, timeline followback, which surveys individuals' patterns of drug use under a particular period of time, the ways in which the data are collected are different slightly between the different studies. And this demonstrates the same phenomenon in drug urine test, which is theoretically very uniform across different studies, but there are still minor subtle differences. And the conceptually similar ways of understanding how clinical trials work and what kind of concepts are common in the treatment of any kind of substance use disorder present significant methodological challenges. But after a decent amount of time, we're able to come up with a proposal of how to do this correctly. And just to help you understand how typically a trial like this works, individuals come in for screening for whether they're eligible to be treated in a clinical trial. There's a period of time when they are evaluated, and if they're eligible, they undergo consent and randomization. And there's also a period of time when individuals are asked to stop using their substance of abuse. And this period of time is typically called induction. And once the induction is completed, they then receive a dose of maintenance medication, whether it's buprenorphine, methadone, or extended release naltrexone, and they're followed week by week after that. If an individual fails induction, they're classified as induction failures, and this is not an uncommon phenomenon, but they're included in the analysis that starts here at consent and randomization in the intent to treat analysis. And this is comparable to delivery of treatment in a clinical setting, where at this period of time, individuals are having an informed consent with a clinician, and you're picking a particular medication to treat for a particular patient. So the clinical question that's relevant in terms of predictive modeling is whether or not at screening with all the data that you have here, if it's possible to calculate a risk score that predicts the probability of relapse at week 12. And in fact, that's what we tried to do initially. We harmonized all the data that we had at baseline and extracted 58 categorical and continuous variables. We changed them into conceptually equivalent categories between free studies, and they encompasses multiple survey domains like demographics, baseline drug use, and so on and so forth. And an outcome of prediction is a single binary outcome of relapse at 12 weeks defined by 4 consecutive weeks of positive or missing urine drug screen for non-prescribed opioid. This is a standard outcome that people have used, and it was one of the outcomes that were used for one of the studies. And we used a machine learning technique called lasso, which you can think of as a dial that you dial up or down to eliminate the number of variables in your model. So if you have this lambda term that goes up, more of the variables are eliminated. And there's an optimal point here where you're including sufficient number of variables that improves your predictive performance, but yet not having too many variables that decreases generalizability of your model. And we eventually obtained a model that had a handful of relevant predictors, but the performance of the model was not great. It was around 70%. And this model may be somewhat clinically useful, and we're putting it together to help us guide decision and prognosis. But it's not really as good as where we want it to be. So we started to think about other options and whether there are many other data sources that we haven't considered. In particular, we were inspired by an earlier study published by Roger Weiss's group at McLean that looked at specifically CTN30 data and showed that the initial treatment response is an important predictor in this group. And whether or not you failed early on really is the most powerful predictor of your eventual treatment outcome. So we decided that we want to perhaps do something a little easier. We want to say that rather than starting our prediction task at the point of screening, we move it up and scrutinize whether we can use the week 1 to week 3 data to predict whether, at the end of the first month, whether or not we know better whether someone's going to relapse at week 12. And it turns out that if we include both the salient variables from baseline as well as the urine drug test screening data in the first 3 weeks, we obtain a much better and clinically useful predictive model. Furthermore, if we only use urine drug screen data in the first 3 weeks, we obtain a model that performs almost as well as if we included all the baseline data. And in fact, we can create a very simple way for everyone to visualize what this predictive model looks like. And if you just look at the first 3 weeks visualized here, 0 is negative and present to clinic, 1 is positive and present to clinic, and 2 is missing and not present to follow up, you can monotonically generate the patterns that people exhibit in the first 3 weeks. If individuals are showing up every single time and giving negative urine, they have a below 10% chance of relapse at week 12. And if people who are having 1 positive and missing 2, or any number of these other patterns, they have 80 to 90% chance of relapse at week 12. And when we saw this data, it's really a very interesting kind of finding. So we did a bunch of checks to make sure that this is a robust finding. And what's interesting here is the finding is independent of treatment group assignment. We can take out whether they were assigned to methadone or buprenorphine. It doesn't affect our prediction. It's independent of whether the patient was inpatient or outpatient. And the effect size of the early behavioral patterns prediction is much larger. And some of the salient variables we extracted include heroin use baseline as opposed to prescription opioid use, injection status, cocaine use, and these are well-known variables that predict treatment outcome in the literature. And yet, early behavioral outcome really overwhelms the effect size here. And not only that, the most remarkable phenomenon is that you can train your model on 1 cohort, and the model essentially can be used unmodified on the other cohorts. And so we can essentially obtain a very simple universal risk score for opiate use treatment, where we have the number of weeks with positive or missing urine test in the first 3 weeks. And if you have 0, then you have a predicted probability of only 13% of relapse versus 3, where you have a predicted probability of 84% relapse. And in particular, this finding is very non-intuitive for those of us who work in addiction, because in addiction, the predominant lore in the community is that it doesn't matter who you are, you have a pretty high chance of relapse when you're being treated. And this is the kind of finding that are reported. For example, this is the primary outcome paper for the Lancet paper that described the outcomes in buprenorphine versus extended naltrexone. And by week 12, if you're aggregating everybody who got into the studies, about 50%, somewhere between 40 and 60% of people relapse. But when you're dividing it up by groups, you realize that this finding is probably too pessimistic. So in conclusion, the main findings of the study is that for those who achieve remission early, medication for opiate use disorder is highly effective. In particular, the risk of overlaps by day 21 is no longer related to covariates traditionally thought to be important, such as heroin use, injection status, cocaine use, and many other things. A single risk score at day 21 works for every patient cohort for every study medication. And if we really want to improve treatment outcome, we probably want to understand the interventions and adapt our interventions in the first 3 weeks. That's the most likely high yield intervention. So I just wanted to say that this represents a really large team of individuals and really big support on senior leadership, both from NIDA and also from the CTN, which Doctors Nunez and Rosen are on the leadership team, but also internally from our Columbia team, where Dr. Levin has been instrumental in developing this new addiction data science work group, and also working with Dr. Melanie Wall's group on the data science team, and also outside with Miami and Emmis. And having a wonderful big team of people to work with has really been a pleasure. And this is our COVID team. We've been working by remote in the last couple of year and a half. And we also had wonderful new additions to our team. And this is my son, Jupiter, who's now 1. And this is Gabriel's new son, who's now a couple of months old. And it's just amazing to see your kid grows up faster than the project growing up. And that's, I think, many times that's our challenge as researchers in mental health. Thank you.
Thank you so much, Sean. What a great talk. Simon, if you can hear me, could you switch the view to standard view for attendees and let me know when that's done?
You got it.
Okay, great. So yeah, we're going to move on to our sort of discussion panel section. If the presenters want to, great. And when you're asked questions, you can feel free to unmute. So I'll try to sort of feel free to send additional questions into the Q&A button at the bottom of your Zoom window. I'm going to start with Dr. Spann. You received a question from Cristiani Duarte, who said, "Great talk, Marisa. How was discrimination measured? What factors were the models controlled for?"
Thank you. So discrimination was measured with the Experiences of Discrimination scale by Krieger. It was developed in 1990, and it has high validity with the Williams scales. I think people might be more familiar with those. And potential confounders. So for the models with neonatal imaging, we always control for age of the child, and we control for gender. And as I mentioned, there's a lot of, this is a work in progress, so there's a lot of other analyses ongoing, looking at things. I think there was a question about depression, as well as acculturation and stress. And so kind of thinking about some of these other factors and how they may interrelate with discrimination, but thus far those have not been controlled for in the model.
Great, thank you very much. And Elizabeth, you got a question from Catherine Monk, who said, "Terrific talk. What was the ratio of men to women in your study? Interesting that there were no sex effects."
Yes, thank you. There were 52% women, so it was pretty evenly balanced. And we actually I didn't expect sex effects, but we checked for it.
Okay, great. And Sean, you received a question from Sally Sattel, who said, "Wonderful presentation. Are you planning an analogous study with stimulant addiction, maybe using contingency management, as there are no anti-addiction meds for stimulants?"
This is a great question. So I think to broaden the discussion, the techniques and methodology involved in this essentially has to do with developing a common data model for clinical trials in substance use disorder at large. And this is one of the core efforts that we're working on right now in collaboration with CTN. And there are several, as you probably know, stimulant use disorder clinical trials that were completed in CTN. So we're working on the grant applications. So also we really need people to help us. So if anybody is interested in this, please talk to me and we can try to get you your help in this area.
Great, thanks, Sean. Marisa, I'll ask you a question. In a racial justice reading group in Area Mind, we read a fascinating and horrifying study about discrepant birth outcomes as a function of racial concordance between pregnant mother and physician provider, which found that for Black infants, there were higher rates of infant mortality when Black mothers were treated by racially discordant physicians, specifically by white physicians as compared to Black physicians. And this discrepancy, this effect of racial concordance of provider and patient was not seen with white infants. So that made me curious in listening to your work. It made me curious, is that a type of effect that you could look at with your data, whether racial concordance of healthcare providers impact some of the imaging measures you're looking at?
Yeah, I mean, I'm just thinking, I mean, it's a possibility that we could figure that out with chart review, because I mean, I think this is really important. More likely, it would be a prospective study, which, you know, is something I'm kind of thinking about and working on. And I think this is a really important aspect of that, you know, because it's possible that there's aspects of mistrust and cultural factors that may be unique to minority populations as well, that would be important kind of moderators in relation to this. So definitely important to consider.
Great. Thank you. Elizabeth, you are up next. There are so many good questions. I'm trying to spread them evenly. You got a question from Meg Haney, who said, this might be too big a leap, but given the role of arachidonic acid on serotonin and depression, and given that daily cannabis use tends to decrease endocannabinoids, do you have any ideas about how cannabis use might be related to your findings?
You know, that's a really fascinating question. There are a lot of metabolites of the PUFAs that have, you know, a lot of really interesting potential relationships with serotonin, dopamine, and depression. And there are studies that have been done with the cannabinoid 1 receptor knockout mice, and which show, you know, relationships in terms of decreased serotonin transporter binding site density. And so I think looking at cannabis use might be really fascinating. I have not personally done any work with that whole side of the PUFA story, but you know, I agree that that's a really interesting potential thing to think about.
Great. Sean, you're up. A question from Denise Candell, who says, great presentation. Did you study the factors that predict status at week 3?
Yeah, we're doing that right now. What's interesting is a large number of individuals, as you can imagine, just don't come back after induction. They're induction failures. And so the issue here is, how do you characterize the outcomes in week 3, in the first 3 weeks? And there is a lot of controversy in the field, actually, especially when you can't directly compare people who were randomized to naltrexone versus people who were randomized to buprenorphine and methadone. And in fact, for people who were buprenorphine, there is no induction failure in methadone to speak of. There are people who failed it early. There are early treatment failure patients. So this is a question that's open right now. We don't really know the outcome. Outcome at week 12 is relatively easier to define. So again, these are methodological issues that we need to resolve before we can even answer that question.
Great, thank you. Marisa, you received a question from Karin Forda, who asked, is the racial discrimination experience that affects fetal development related to the experience during pregnancy? And then she said, and or the cumulative discrimination experience across life. I guess maybe you could even speak to the scale. I think a lot of us, you mentioned the name of the scale, but I think for a lot of us who aren't in the field, we don't know, what that scale is asking about. So maybe you could, along with your answer to Karen's question, describe like what it's looking at a little bit more. She says, that is, would specific interventions during pregnancy be effective as a first step to break the cycle, or is it already too late and only earlier interventions likely to help?
Yeah, so thanks for that question. So this is not a measure of cumulative discrimination. So it would be with sort of a specific time frame. I can't remember if it's sort of within a month or not, but it definitely would be within the pregnancy time period. So, it is definitely possible that intervention could be useful. Now, that doesn't mean that sort of the big picture cumulative experiences of discrimination a woman may have may not be factored here, but this particular measure is not measuring that. Sorry, does that answer your question? There might have been a second part.
Well, I think she was just asking about then what it would suggest in terms of time to intervention.
Okay.
Like
And
when
then,
would be a window to intervene? Yeah.
and then example of a question on the scale. So something like, do you feel like you're followed when you're in a store? So they are pretty kind of specific questions, looking at discrimination.
Great, thank you. Elizabeth, I have a question for you. So it's powerful data that you shared, and I hear you that it doesn't speak to causality, but there are things that you could do to look at causality. I mean, it doesn't prove causality, but there are things that you could do to examine that. So my questions are, well, first of all, if there is this inverted U-shaped relationship between arachidonic acid and depression severity, it means, I guess it suggests there's like an optimal range for like depression health, right?
Right.
And so the first thing that comes to my mind is like, how modifiable is arachidonic acid? Through diet, through dietary supplements, through different PUFAs, like, do we know how much we can change someone's arachidonic acid level? And then have you thought about like an intervention study where you might look at an intervention, its effects on arachidonic acid, on serotonin transporter levels, depression severity, et cetera?
So most of the dietary studies have been focused on increasing omega-3. But there are some researchers who are looking at it. Usually they're looking at trying to decrease arachidonic acid. I think there have been some studies on this, maybe with regard to migraines also. And the arachidonic acid story may have a lot of relevance for bipolar disorder, which I didn't speak about here. But so the studies that I'm aware of are looking at that. Arachidonic acid is all of these are essential dietary nutrients. You can only really get them by diet or supplementation. So in Western countries, we have a very big intake of arachidonic acid generally. It's in a lot of protein containing foods, and so it's a little bit. It's harder to make an effect, I would say, than adding an omega-3, because we tend to be very, very low in omega-3s. I won't go into that whole thing, but the answer is yeah, it's potentially feasible. Personally, I'm much more interested in going the other direction and looking at the lipid raft. And I've been doing some preliminary work with NMR, trying to see whether we can measure how sensitive NMR might be to looking at lipid raft structure in relation to PUFAs in the diet. So I've been working more on that end.
Great, thank you. Sean, a question for you from Mina Risk. Did you look at comorbid depression in the risk predictive model for relapse? And if this is different within treatments? He said, as we found in CTN 51, depression improves more rapidly in the first 4 weeks with buprenorphine versus naltrexone.
Yeah, so it's interesting. There are, to just broaden this a little bit, there are other variables outside of UDS that were measured in the first 3 weeks, which can potentially, depression recovery being one of them, that can potentially also augment the predictive power. Now, that said, we have to think about clinicians. We can't have clinicians measure every single variable in clinical practice. So these models and their utility is somewhat hedged by that equation as well. But I think that we're moving in that direction right now in this project.
Great, thank you very much. And then Marisa, a question from Mike Grunbaum. What do you think are important mediators of relationships between maternal discrimination experience and offspring brain connectivity? For example, maternal attachment style?
So I think that that's a great one, maternal attachment style. I've been particularly interested in acculturation as potentially moderating the effects of discrimination. And And I think, you know, it's a right now this is sort of retrospective analyses, and so I do think if I as I'm thinking about a prospective study, there are a number of additional things to consider. I think a maternal attachment style would be a great one as well.
Great, thank you. Let's see. So Elizabeth, John Kelp says that notes that you got high correlations between DAS binding and the 17-item Hamilton. And he wonders if you looked at sort of other depression scales like the 24-item Hamilton or the Beck, since elements of those scales or the full scales themselves are more closely associated with suicidal behavior. This might address some questions regarding the role of serotonin binding in depression itself versus suicide risk.
Yeah, I think that's a great point. In this particular sample, we only had 3 suicide attempters out of 21. So, and the sample itself would be too small, I think, to parse out. Even if it were better distributed, I think it would be too small to parse that out. But I think that's a very good point.
Sean, I'm going to ask, I'll take the opportunity to ask you a question as well. It's a little bit related to what you were speaking about with the last question. You were saying there are only so many things a clinician can assess, right, and ask about that might be relevant to a predictive model. But since none of the clinical or demographic factors that you looked at really seem to do a much better job than just the outcomes, the early outcomes in the first 3 weeks, what I was curious about is, like, if you had a time machine and could go back to the beginning of these studies, are there other measures that you would have wanted that you think might have done better than, or added to the information from the early treatment response, that might have done better as universal non-specific predictors to improve prediction, or might, you spoke in the introduction about patient match, right? Like a long-term goal of, I said, personalized medicine. Are there other things that you think might have gotten you farther along that were not measured in these studies?
Yeah, so this is, of course, something that people are constantly talking about when you're talking about precision medicine, and also in the design of new studies at CTN in terms of broadening the scope of treatment or doing adaptive treatment and things of that sort. And, if I was trying to make everybody happy, I would answer things like genetics or neuroimaging or any number of these fancy toys that we might have to gather data. And I'm just going to kind of go off the rails a little bit. And I think actually what's going to be most fruitful is your previous track record of treatment response, which is very similar to your current treatment track record in your treatment response. So I think of this as sort of a risk score, and we're trying to build up a grant application to do this real-time risk scoring for treatment response, which is similar to something like a credit score, where really it's your previous records of how you do in general that's the most effective predictive assessment. So I think clinicians, as they think about this, these are the ideas in how do you quantify methodologically people's engagement with treatment historically, and come up with questions that would effectively survey that domain. I think that would be my answer.
There are clear, and Jonathan, I'll let you pipe it in 1 second. Just there are analogies between what you're finding and in depression and suicide literature, right, where a history of a past suicide attempt is really the most potent predictor of future attempt. Jonathan, you were going to say something?
Yeah, I was going to actually ask a question for Elizabeth. I was wondering if you could speak a little bit about the role of omega-3s in neurodevelopment. And I guess specifically what I'm wondering about is the impact of omega-3s already sort of baked in by the time someone reaches adulthood, or is their more recent adulthood intake still play an important role?
The effects of omega-3 are, I think, throughout the lifespan, you could alter somebody's brain environment with supplementation. It takes about 8 to 12 weeks to kind of equilibrate the effects of omega-3s. And there are some interesting studies. There's a study in how I believe it is, that mothers taking omega-3, nursing mothers taking omega-3, that there was some kind of genotype mediated effect on babies' cognitive function, some complex thing like that. So, I think it's an intervention that could, really be done, throughout the lifespan.
Jonathan, do you have other questions for our speakers?
No, I don't. Thank you so much for asking.
Okay. There are a few other questions. I think I'm hoping to get to, I think, just about everyone. Marisa, from John Mann, you were asked, did the race of the husband being the same or different to the mother affect the results?
Did not look at that at all. Obviously, these are adolescents, so some of them we're not going to have information on partners, but that's definitely something I could take a look at, and it's important as well.
Great, thank you. And then Sean, you received a question from Mike Grunbaum. Could you comment on kratom? I don't know if I'm pronouncing it correctly, an opiate that seems to be legally obtainable.
Yeah, kratom is a very interesting question, and there are actually a lot more than kratom. There's hallucinogens and other unusual substances, and it turns out that there are free texts in the surveys that we're talking about that contain all the patterns of usages of these unusual substances that weren't tabulated in the regular forms. And the study actually provided one of the first opportunity to scrutinize this in this cohort. And we have some results, so be prepared to see them soon.
Okay, good. That's a good teaser. And it's nice that we can sort of have something that approximates an in-person conversation. Marisa Christiani had a follow-up to my question. So important to add to the study of discrimination, the role of structural racism, but not easy to measure or separate the effects. So glad and important that you're working on a follow-up. Would you hypothesize different effects or perceived discrimination and structural racism on maternal brain function and then further offspring? So that I think she's asking, just to make sure I understand it, you may understand already, like a different effect between A, perceived discrimination, and B, structural racism, I think.
Yeah, I agree. This having both in a study is really, really critical and essential. One of the things that's been interesting for me doing this work on discrimination is that a key piece of this is how you perceive it, right? Because you could be in an environment where there's a lot of structural racism or discrimination, and it's whether you perceive it or not, which is also why I'm particularly interested in acculturation to see how sort of that buffers or relates to it. And Christiane, I would love to talk to you offline about moving a prospective study forward in this area, because I agree it's going to be tricky to study structural racism.
So I think we've covered a lot of ground and I hope I got to almost everyone's questions. I apologize if I missed yours. Jonathan, anything else we should discuss before we wrap up?
No, I just wanted to thank all the speakers. These were really wonderful, really inspiring presentations. And thank you so much, Jeff, for emceeing. As always, you do a wonderful job.
Thank you so much. This was wonderful.
Great job, Jeff.
Thanks. Bye, everyone.